It's very glad to have you here, my dear, my mentor, my idol, my guru, Dide Dieci.
Thank you, Engin. Thank you, Engin, for your warm welcome. As you know, friends are always over-optimistic when they speak about you. Thank you anyway very much, because in those days, Engin, when we are offered flowers, we gladly accept them. We are not in a period we will refuse flowers. So thank you very much. You are a very dear friend, and I don't know who is the master of who, but I think it's a long debate, so we'll not enter that discussion. And I really appreciate the opportunity that I'm having tonight to be chatting with you and the whole group, all your followers, and there are many, obviously. And I'm looking very much forward to the session and to enter the discussion.
Thank you very much, my dear. If you let me, I can introduce you to our colleagues in Turkish a little bit. And
yeah,
then,
sure.
because as you know, I didn't learn English in school. This is all by ear during the years. I rather prefer to do it with you, this session in French. Ça va? Ça va, mon ami?
Ça va très bien aussi.
Très bien aussi, mais it's common language is English. We have to do that in English. But somewhere, somehow, in a special part, I can maybe to translate you to my friends, because there is a lot of people. There will be a lot of people here. There are some students. There is some new graduated people, and some. Most of the majority know English very well. But maybe in some small areas, I can translate you, okay?
Sure. You let me know when you need to translate, so that I stop talking.
Okay, according to the comments, I will see them, and then if there's some translation needed, I will tell you, and then take from you a couple of seconds, and then to continue, okay? Let me first introduce and express myself in my language to my people, and then we can continue, okay?
Perfect. Good.
Evet arkadaşlar, Dide Dieci, çok sevgili arkadaşım, dünyanın söylemiştim sayılı akademisyen aslında. Ama aynı zamanda klinisyen. Cenevre'de çok güzel bir muayenehanesi var. Leman Gölü'nün hemen kıyısında, orada bir su fıskiyesi vardır. Hemen onun önünde 2 katlı böyle büyük bir bina. Alt katta kurs merkezi var. Üst katta çalışır. Cenevre Üniversitesi'nde de çalışmalarını sürdürür. Birçok yayını vardır. Benim bu camiada en güvendiğim, en sevdiğim, en bilgisine de güvendiğim arkadaşlarımdan biridir. Ondan ilk tanıştığımızda, onu şimdi konuşuruz, bir kurs sırasında tanışmıştık. Çok yıl oldu tabii ki. Sonra çeşitli yerlerde konuştuk. İstanbul'a geldi gitti. Bir sürü bir buluşmalarımız oldu. Çok kıymetli bir duayenimizdir. Okay. I think it is okay.
Totally agree with you.
Thank you. When we met for the first time, I don't remember, but from years, I think it was in Geneva, maybe with Roberto in the posterior indirect restorations or so. There was a course in your the other.
Exactly, and you were a good friend.
Selim was there. Selim Pamuk.
Yes, exactly. We were with Selim, and we were having the program partially in the old office and also at home.
Yeah.
We had the coffee breaks outside on the terrace. And that was quite a few years ago. I would say nearly 20 years ago, something like this, at least, if more.
At least, yes, 20 years ago. And I little bit improved that technique, and I put some Lego toys for the key and make an article for that. It was very good technique. I use it too many times, and nowadays I work with CAD/CAM systems, but that was a very good idea, a very good technique.
Yeah.
And tell me what happened there. How are the things in Geneva, in Switzerland, in this pandemic thing?
Yeah, in fact, as you might know or not, because Switzerland, of course, is such a small country that the numbers of COVID-19 cases seem to be relatively low compared to many other big countries. But in fact, I don't know if we still are. Maybe Spain went a little bit over us or in front of us, but we have been for quite some time the country in the world with the highest incidence of COVID-19 infectious cases or infection. By chance, the number of deaths has been relatively low, although we also have tested only people coming to hospitals. We haven't done any systematic testing. So the situation has been not so good, in fact, but because we have a lot of places in ICU in hospitals, the crisis hasn't overwhelmed our medical structure. But it's not because it did not overwhelm the medical structures that we have been escaping from the pandemics. Now we are returning to work, or officially we were able to return to work this week. And in fact, for us in our practice, as everything is missing in terms of protective, we are only starting to get things in, but anyway, not enough to basically provide what is needed to every dental or medical office. We decided to push the opening of or reopening of the practice to next week. We are still battling to get, we have enough basically to work for 2 or 3 weeks, but now we are really fighting, trying to get gowns, hoods, proper masks, disinfection, let's say alcohol. It's really a fight. It's a war to get material. Patients are ready to come back. Surprisingly, I would have expected maybe at least 50% of patients being reluctant to come back, but in fact, we have nearly not enough patients willing to postpone the treatments to be able to reschedule now the 7 weeks we have been in strict confinement. So now we are going through a real nightmare because everybody wants to come back, but those who are scheduled now in the agenda, they want to come too. So we just, our staff is getting totally mad, trying to find people who agree to postpone their treatments. I can tell you, difficult patients before the COVID crisis have become just more difficult to handle after the COVID crisis. It has not done anything good to the mentality of people. Good people are still good, bad people are still bad. If anyone had any expectation on this, I can promise, forget.
Okay. Do you think we can go to our normal working routine soon?
No, in fact, in Switzerland, and I don't know how it's going to be in your country or how much guidelines you have received, we are officially allowed to return to work, but under certain conditions. So we have 5 pages of guidelines that we have to follow, which I would say are, for the large majority of them, are quite logical, but still based on the fact that we are missing protective means. So they are if we know a little bit about this crisis and this virus, and I've been personally reading a lot just for my interest, and we are far from doing everything we should. So we will do more than what is requested by our authorities, trying to keep the staff, patients, and ourselves safe. But we need also to observe a minimum of 30 minutes in between each patient. in order to disinfect with a special spray the whole, because we have very large operatories. So we cannot have any little machine just to filter a little bit the air. It would be completely inefficient in consideration of the size of our operatories. But this is also a recommendation. You are not allowed to take patients one after the other. We are not allowed to get patients waiting. They should, when they arrive, they should get straight into the operatory. This shouldn't be a big problem. Now that we got organized to keep enough time in between the treatment, that will tremendously lower the rentability of our activity. Honestly, we don't know how well that will work, but I think we need to serve our patients. This is the first thing. We need to return to work. We need to learn, because it's really heavy. The last couple of weeks, we have been only treating emergencies. So we tried to learn the proper measures, really COVID-19 specific measures. But it takes a little while to get take the right. Maybe when we are sitting next to the patient, there is nothing so difficult. But at the moment we finish the treatment, we stand up. This is where we do a lot of mistakes, because now we should not bring our disposable gowns outside. We should prevent of moving out. We should prevent of touching everything that we were used to, not touching everything, but there are so many little mistakes we do in the CC process, but I hope we'll learn quick. I hope we'll learn quick and we'll be able to operate really very safe way again for the patients, for us, and for well, the staff of course.
Yeah.
How is it? How is it in Turkey? Are you allowed to work or are you locked down?
No, they say for the moment only the urgent thing can be done. Actually, I have to go tomorrow for my patient that last week we have to treat endodontically, and then we have to finish the case. But we will see after a month. We hope to go slowly to our work, but not routine, I think.
No, it's not going to be. It's going to be very different from the way we have been operating up till until the crisis. And everybody is saying, I don't know if this is right or not, but everybody is saying that we'll never work again after the COVID-19 crisis as before. It's going to be a definitive change. And it's difficult to measure how much this will impact our profession. I mean, also financially and in terms of organization, in terms of staff resources, in terms of equipment resources. That will certainly have some significant impact, but difficult to measure right now.
Okay. Do you believe that we can work with these highly protective equipments like astronauts with things?
No, definitely. I think it's like, the aerosol. Can we use high-speed instruments with air spray? Of course, for us, it's not a big deal, the story about rubber dam, because we do everything on rubber dam routinely for whatever can be done on the rubber dam. Me, I've already taken for myself and my patients that there is no scientific evidence that if we use ultrasonic instruments or turbines, of course, we know that we can spread the aerosol a little bit further. But people who know really about infectiologists, I heard them saying what is probably beneficial with, let's say, an aerosol that you spread around is that you will dilute the viral load. It's not my statement. I'm not considering myself as a virologist, but people who understand certainly a lot more than I said, it's not such a bad thing. Instead of keeping close around you a highly infectious aerosol, you will dilute and it will become less dangerous than what you keep just around you by breathing if you're infected. So me, I have no, for now, until I would prove wrong, I will not change my way of working. We'll probably use more efficient suction, but in the mask, I don't want to cook bulbs. I don't want to do a wrong, or let's say a low quality treatment because of the COVID-19 measures, in the sense that either I can work safely and in a good way do it, then we need to postpone treatment. But I will not work on vital teeth with no air spray, with no water spray. Doesn't make any sense, this. So we'll use the rubber dam as usual, because we use the rubber dam for everything that can be done on the rubber dam. For the rest, apart from my equipment and the face shield, the glasses in front, or let's say protect the eyes, bubble mask, hood, the sterile gown. For the rest, and this I've already tested, it works. For the rest, I will work in the mouth as I did in the past, no change.
What about that face shield? Face shield, they open that area. The patient is here. Face shield will not.
It's only to prevent direct projection into the eyes, but it doesn't protect in any way from the aerosol or anything that is produced. It's only that you don't get. It is true that when you look at the face shield, it's quite dirty at the end of the procedure. So it means that just these little droplets that are projected into our eyes or close to the eyes, we want to protect a little bit, but it's nothing. Nobody pretends that it is protecting from the aerosol or breathing. What is very important is the only thing that I think I will consider as maybe the most important measure for myself to protect myself is to make sure that my mask is well adapted.
Yeah.
Because if the mask is open here and here, here and here, I've just been reading today an article, or it's a report about the infected people in hospitals, and they were able to monitor departments treating COVID patients and those having FFP2 or FFP3 masks and classical surgical masks. And the rate of medical staff being infected by the COVID was higher in the group of people using FFP2, FFP3 masks. The only reason is not because of the quality of the mask, but because of the poor anatomical design of those masks that do not allow the mask to really fit, or the construction of the mask doesn't allow the mask to fit properly the face. And then it serves nothing.
Okay, nowadays we are looking for the external vacuum system. There is some devices that you can take a little closer by the patient, and then maybe we can have some benefits from that one.
Yeah, I don't know. I don't know, because I've not been trying it. The only thing that I can say, because my niece is working at the hospital with COVID patients, not in intensive care, but she's in a service where they are treating COVID patients. I can tell that their protective measures is at a very, very, very low level compared to what we will have in our dental practice. What you have seen in China is only in the ICU, and I'm not even sure here in Switzerland if they are equipped that way. I'm not even sure. But nearly nobody is getting sick. So with very low protective measures, but good protective measures, a mask which is properly adapted, a hood, surgical gown, that's all what they do, even when they get in regular contact with COVID people. And apparently nobody is getting infected. The few ones who are being infected seem to infect themselves in, let's say, outside the professional environment. Eventually in the lockers, at the cafeteria, they meet together, they take out the masks, they drink a coffee, they laugh, they get too close to each other, and this is how they are getting infected. Even if it's not 100% protection, what's clear, if we do the minimum we have to do, people will probably not get infected at the practice, neither patients nor the staff. But we need to make sure that the basic measures are being properly applied. Okay. This is a little bit what the scientific community is sharing by today as the most accurate information. Hopefully they are right, having said that.
Okay. By the way, I saw Francesco Magnani was here. Francesco, yeah. See you.
Oh, ciao, bello. Come stai?
Ciao, ciao. Ciao. Next time with you, Francesco, huh?
Okay. And let me know
now
again, Francesco, as the talk with you, let me know. Huh? I will not miss this.
Okay. Why not? Now we can pass to our topic, anterior direct composite restorations. What do you think? Can you tell us your knowledge a little bit to share something?
Yeah, I would like maybe to start with a consideration which I think might make sense in these days. I don't know how many of you might have been at the IDS last year, but for those who have been visiting the IDS, it was already quite spectacular at the IDS 2017, but the IDS 2019, it was just even more overwhelming. The amount of CAD/CAM technology, 3D technology, all kind of imaging technologies, virtual reality. And honestly, it's so overwhelming that when you find yourself all of a sudden in front of the booth of a company producing composite, you see the sciences of composite, which format and function hasn't changed for now, let's say, nearly more than 40 years, nearly 50 years. You ask yourself, but maybe it's just a material from the past and there is no future. We'll probably very soon be able to 3D print in the house. Why should we not do everything CAD/CAM? And honestly, that made me very, very thoughtful, because you and I are teaching composite and we are doing also CAD/CAM dentistry. But I was really thinking, will I still have people who are interested to take my courses? Well, this is just a personal view, but also, will the dentist still continue to do composite? And I think the answer today is very clear. In the next 10 years, new technologies will not take away direct bonding, in no way, because indications are different. What you do with the CAD/CAM system, or nowadays what you can do with 3D technology, is in no way going to replace composite, at least for a decade. And I think even it's going to be more than a decade. Try to imagine we might find a machine, optical impression. You can record the shade, of course, that's fantastic. Try to think about a machine which is able to 3D print in the mouth a highly filled composite or a new restorative material that might have all the mechanical and aesthetic properties of composite. We have nothing like this by today. That can print perfect way and replicate all the colors, all the anatomy and everything from the tooth. Do you think that a machine like this would cost $5,000? No, that would cost a fortune. So what would be the price of a direct restoration or something 3D printed in the mouth? That would become very expensive. So I think it's so easy if you have a simple protocol to master direct bonding relatively. We just need to learn. We just need to give ourselves the time to learn. We'll not do perfect restorations the first day. If we are a young student or a young dentist, it will take a little while. But if you wish to produce quality, you can produce quality in a rather efficient way. We don't use 5 layers. We don't use 4 layers. We will use 2-3 different layers for the majority of restoration, so that it is feasible to control the shade, and same for the anatomy, primary, secondary anatomy. There is nothing that will replace the bonding for a lot of indications for the next 10 years or more. I think it is quite important to tell the young dentist, don't think that new technologies will replace this technique. I hope you agree with me, Engin.
Just a second, small translation for the guys.
Okay? Sure.
Okay. Arkadaşlar, muhakkak herkes anlıyor ama belki yayın kalitesinden dolayı da duyulmamış olabilir. Kısacık özet, Didier'in söyledikleri. Son IDS Köln'deki toplantı 2017-2019, 2 senede bir oluyordu. 2019 IDS Köln'de de görüldüğü üzere çok sayıda CAD/CAM teknolojiler gösterildi. Ve her şey sanki CAD/CAM'e gidiyormuş gibi gözüktü. Fakat Didier'in de dediği gibi en azından bir 10 sene daha direkt kompozit restorasyonlarının yerini öyle kolay kolay CAD/CAM teknolojiler alamayacak dedi. Özetle. Okay, my dear.
Okay, this is really, I think, for me now, pretty much in every program that I'm having, I start with this because I think this is the basic idea that I want to share. Composite is not a product for dinosaurs. I'm a dinosaur, but it works for the dinosaurs, but it works also for young animals. So that's really the basic point I wanted to make.
Can I tell you one more thing?
Yeah.
If you don't move your telephone, your voice comes very nicely. Please put somewhere, which is very good, because I evaluated the voice. This is better like that. If you are happy with that, I don't know.
Yeah, sure. No, it's only, you know what, I've taken, I was holding the telephone where there is the microphone, so that's why.
No, put somewhere still, and then the voice comes clearly to us.
Okay,
it's very good now.
I have nothing to hold the telephone, my dear. In the dinosaurs hut, there is no such a device. So it's my hand. It's my hand.
Put the glass in behind, please.
Huh?
Put some glass or something and behind.
To hold it. Okay, maybe I can find. Maybe I can find something. I would try. I would do
because your voice changes according to the moment.
To the moment okay, I will see what I can do. I don't
give you if you like. Okay. Başım döndü arkadaş.
Because I've done all these webinars with us. Okay, let's take out the cable and see if I can hold it like this. Is it working? Perfect. Because good.
Perfect.
Excellent.
Perfect. Thank you very much, my dear.
You are more than welcome.
Then do you believe that patients require that like to have these direct restorations instead of the big the other protheses or so? After that pandemic thing, they will maybe convince themselves to do the quick restorations in one session or so. What do you think about these?
No, there is clearly there are different reasons to select one technique rather than another. One of the reasons is to have it cheaper. Another reason, get it faster. And another reason, which I believe is very important for us, is eventually to be able to do it in a more conservative way. So it means I can do it direct, so that I don't need to prep. I don't need to do any extra preparation. That's also one of my thoughts that I had lately, is to see whether there are a lot of indications where we can use different options. There are few, what I call the gray zone, which means there are clear indications for direct, clear indications for indirect or CAD/CAM, and there is always a gray zone in the middle. But I don't think in the majority of cases. There are some restorations where we obviously have no other choice, whether because of the size of the cavity, whether because of the age of the patient, whether maybe because of the financial environment, socioeconomic environment of the patient. And then the choice normally is relatively clear. Well, if you do form corrections in a patient age of 50, I think we can do, if the patient is a low budget, we can do it with direct bonding. If the patient has money and wants to get the top of the top of the top, we might do super conservative. No prep, I think there are not a lot of indication, but minimally invasive ceramic veneers, it's fine. But I don't think there is, for me, there isn't a lot of controversy in regard to the good indications for direct bonding and indirect bonding. For me, what is very often helping me also to make the decision is something that I forgot to mention, which is a little bit different in the gray zone, is your experience and skill with the material. If you're highly skilled, you can do a lot more with direct bonding, but I don't think you would never do a full mass rehabilitation like crowns or restorations and implants with direct bonding. It's just not the indication. If we need to do little corrections on a young patient post-orthodox 15, I think nobody is going to go with CAD/CAM. Unfortunately, they are going with CAD/CAM and indirect. But normally, the standard of care is direct. So I think the choice is not that difficult in my eyes if you follow the indications, the known indications for different techniques.
Okay. Do you think that the prices will a little bit go higher?
You mean for composite because of the COVID crisis?
For direct composite, because they will choose according to the pandemic. After pandemic thing, they will maybe
if that would if the situation post COVID crisis might give an opportunity. So somebody's dinosaurs hunted us, dinosaurs as coronavirus. That's some nice remarks. If the COVID crisis might give a little bit support to direct bonding, that would be a positive impact. I'm not so sure about that. It is true that we all know that direct techniques have been always undervalued relative to indirect and CAD/CAM. I still believe by today, and I'm sure Engin, you will agree with me. Ciao, Federico. I think
Federico, ciao, ciao.
A good composite, even a very good composite, can maybe not compete with the best ceramic work in the world. If you take the top ceramics, the price is also not in the same range, right? But between the bad composite and a bad ceramic, I think the bad ceramic is much worse than a bad composite. Because aesthetically, you can never hurt the patient so badly as with bad ceramics. And even average ceramic veneers are aesthetically a lot worse than average direct bonding. That's my, well, it's not my idea, it's the reality. So when we compare different materials, we cannot only compare the veneers of Pascal and Michel Magnier with composites of a non-skilled dentist, which normally we do. We need to compare what is comparable. And I think composite is a very decent material that deserves, to come back to your question, which deserves to be better valued, because we provide, if we take our time, we can get better, let's say, better compensation for what we do. And if we get better compensation, that will also provide more time to the dentist to do the perfect job. But if we are in a pricing system in so many countries around the world, including Switzerland, maybe even more in France or Great Britain, where the price being paid for the direct bonding is so low that, of course, you cannot provide anything decent, or you lose money. You can decide to lose money as a service you provide to the patient, which I greatly admire. There are dentists in the UK, in Belgium, in Netherlands, in France who are doing incredible work. They cannot really charge for the quality of what they do, and I have a lot of admiration for those people. In Switzerland, we are very lucky because it's mostly a private system. It doesn't pay as much as when we do Prost, but we can earn our life in a correct way. So if this can be improved, the situation post COVID, that would be fantastic.
Okay, let's go, if you want, a little bit the slides or technique that you will tell us.
Okay.
I can show you also your case here if you like.
Yeah, so maybe you can. It's really up to you if you want to present maybe from your side on the Instagram. Otherwise, I will move to, and I can show you some more cases afterward. But if people can see the case, yeah, it is.
If you like,
great.
you can show us this case, and after it's up to you. After the comments also, if we have some questions about, we can.
Yeah, sure. So if you agree, I will maybe start with a case which is maybe a little bit simpler, or or maybe let's start with the case which I presented, and then maybe if people have interest, I can show some cases even more complex or less complex, but still I think in this concept of being, so I'm just opening up now the case. So this case, which you see now on the screen,
this is the same case.
Yeah, it is the exact same. Yes, exact same case which you see on the Instagram screen.
Okay, we can go both sides if you like, because you have a little bit the comments on your picture.
Yeah, I can. No, but it's okay. I can see it, so it's okay. You prefer to go only on your screen, Engin, on the upper part?
It is better missing only the canines. If you are okay for you, this is better.
Yes, of course. Yes, of course. Okay. So the patient was 15 years of age when we started, or when we have seen the patient for the first time, and the patient was basically just finishing orthodontic treatment. I appreciate the fact that it doesn't look like the patient just completed the treatment. We did a quick
sorry, Didier. They say close the comments, but I followed you in the same slides as you did. Okay, they can see upper part also.
Okay, perfect. Thank you.
Yukarıdan izleyebilirsiniz. Aynı vaka arkadaşlar. Okay.
Okay, so now maybe what was not visible from the front or from the smile view is that we have huge, let me just, we have huge spaces. We have huge spaces here, okay, or on the left side. So now I have here a mesial-distal gap for the canine, which is more than 9 millimeters. So I have the roughly 7.5 millimeter of the canine plus space mesially on the left side and distally on this side. So that made, in fact, the case very, very difficult. So what we did again a little bit of Invisalign treatment to redistribute the spaces better. We did a little bit of bleaching. This is my colleague Viviana who did the Invisalign treatment. And at the end of the treatment, we had not an ideal situation, but the case was much, much easier to handle. We have done a second digital imaging on the case with a template having basically tooth appearance or tooth color. You know the system now, you adapt basically the template canine to canine, then you can make whatever modification you like to. It's a purely 2D, and we do it on PowerPoint or Keynote. That's extremely efficient compared to any 3D system. That's also something which is important to say. For composite cases, I will very rarely go for a 3D digital analysis unless I want to have a snap-on. So I will show you maybe one case with a snap-on, then we did the analysis 3D, but here I will do it freehand direct, and I wasn't in need of any basically wax up or snap-on. Then I have taken out...
Sorry, Didier, what was the name of the program that you can put on the Keynote?
Keynote or PowerPoint, yes.
No, that 2D program name.
No, 2D is only, when I'm saying 2D, it's just meaning that you do it on a still image. You don't use a 3D file. It's done on the...
I just want to know the name of the program or so. You can...
but it's not a program. It's just it's Keynote. Me, I did it in PowerPoint. The templates are PowerPoint, but the same templates you can use on PowerPoint or Keynote. And it is just done into, it's an animation that I did with the PowerPoint, but that's exactly the way we do it.
Okay, okay.
It's not a dedicated. You have dedicated programs to do that, of course.
Okay.
You have even sort of virtual reality. You certainly, well, you of course know, but maybe your colleagues know or don't know the Ivo Smile. You have some virtual reality programs that allow you to do this dynamically, which is not the case here because we work on still images, but it's very easy and very effective. And I think it's a good communication tool for patients. Okay. So here, as we were not willing to lengthen the teeth, we were not changing profoundly the smile line, we decided not to do any mocha or snap-on. And we went directly, so basically we have alternative options. I'm just getting a little bit closer. Of course, we can have a digital wax up. We can do it then 3D or 2D. Then we can produce a snap-on mocap or do a conventional mocap with a silicone index. But here we haven't done it because this is for me what I call a simple case. We only work on the mesial-distal diameter and we do form corrections, but without an important modification of the smile line. That is for me the most difficult cases is when I need to lengthen the teeth, change basically whole proportions, dimensions, and form. If I need to do that, I like to get a 3D planning. 3D planning, it could be with a wax up or with a CAD/CAM approach. So here, with Roboderm sectional matrices, maybe I can come a little bit closer so that people can see. With sectional matrices, we altered the profile. We closed the space, adding a little bit on the central, on the lateral, until I could basically complete the whole build-up. Here, the entire smile build-up has been done in one shot, one session. We don't have extremely large quantities of material to apply, only the premolars that we transformed into canine. Here we had a little bit more volume, of course, to add. And that is just the immediate past of view. You see that the gum is still a little bit irritated. The canine on the upper right is still a little bit too bulky, but it's just the first shot. I haven't done any correction. Right. And that is a little bit, this is with the template to show that we haven't been too far from the template. And this is basically, no, we don't see so well. I'm sorry, there is a little bit of light reflection.
So my screen is better than yours now. If you look at that.
Yeah, exactly.
They can see over there also.
You have the original images. Excellent. Thank you, Engin. And now you see that I have retouched the profile of the canine here. It was very bulky. This is actually a premolar, but now we have given more facial volume. We have given again the form of a cuspid, let's say a cuspid teeth. And also here, I mean, it looks a lot more like a real cat. We used only two shades, basically, body shade and a skin shade. Body means dentin, skin means enamel. And
these are the your composite, isn't it? Inspiro.
Absolutely, absolutely.
Yeah. Sorry, and people may know Didier is an inventor of a composite system called Inspiro, but we don't have yet in Turkey. Let me translate in Turkish also.
Yeah, sure.
Didier bir kompozit sisteminin esasında designer'ı, yaratıcısı Inspiro diye. O kompozitlerle yapılmıştır. Because people will ask which material do you use.
Okay.
That's the answer. Okay.
Thank you very much. And we used a little bit of effect shades. They are flowable composites. like here the Azure, and the Azure is a blue tinted apalescent material, and a little bit of ice, which is a white tinted aesthetic effect shade that allows to characterize the restoration, to give it a more lively appearance, so that it doesn't look too monochromatic.
Yeah.
And this is some views a little bit later. It's already a couple of weeks later, and well, with the black background, it doesn't look good. This is the smile of this young patient, and I think that's probably all what I wanted to show in this case. This is here nearly 2 years later. You see that if I'm getting a little bit closer, we still have a nice gloss of the composite. No form change, no fracture, no chipping so far. Of course, it's a little bit less than 2 years, but I think it's a very decent result. And I like this case to start this discussion because it's a young patient who could possibly try to do something with CAD/CAM. But when you do this kind of form modification, these are not having necessarily the perfect geometry to go with a no prep approach. It's not going to be that easy. And me, I can in 3 hours, I can start and finish the case. If you do it with CAD/CAM, it's going to be more steps involved. You will never reach maybe this aesthetic quality, because monochromatic composites don't get this lifelike appearance. And of course, if we go with ceramics, which is an alternative option, it's going to be a lot more expensive. And I think in a young patient, we know that the gingival profile might change. She's only 15 years of age, so the gingival profile might change. We might get a little relapse of, I don't know, tooth position, whatever. I can make corrections. I can make corrections anytime, whenever needed. If we do anything CAD/CAM indirect with ceramic, we are very much limited with our ability to make corrections. So that's why I like so much this approach for young patients. Again, as you said, Engin, we don't say that composite is a universal skill that can solve any case, but that is, I believe, a good indication for composite. So I think we can probably now discuss a little bit the case, I guess. And I return to my view.
Okay. Very good, my friend. It was a non-prep restoration, isn't it?
100% no prep, exactly.
Yeah, just only etching and bonding.
Exactly. Sandblasting to clean the surface after placing the rubber dam, because we still had a bit of composite. It's very easy to take it away with a sandblasting device or with burrs for someone who doesn't have the sandblaster. And it cleans completely the surface. If you have little remnants, biofilm, anything that will interfere with adhesion, you can take it away with the sandblasting and the micro etcher.
Okay, well, thank you very much. Thank you very much. If they have some questions, I will check. You can also check, but it was very clear. Because I follow you also with the on the upper screen, the left of my face. They can easily see what happened. Mine are a little bit narrower than you show us very good to canine portions. It was very good. Thank you very much.
Okay, so okay. People already we have at least another 10 minutes. I don't know if you want me to show well some more cases, some more information, maybe on the case where we used
Didier, maybe we don't have too much time to make another case. They will be obviously maybe there will be obviously some questions, but let me ask you some questions about the matrices system, because I have a lot of questions about that topic. You said these are the transparent matrices. Are they special matrices for anterior, or you are developing them according to the case from posterior matrices? What do you use?
Okay. Then I will reply also the questions regarding to the finishing and the polishing. That's a good question, because matrices, to be honest, we are all fighting a little bit with matrices, because there are quite a few systems, but so far I couldn't find any ideal system that works in any. But in that specific case that I've been showing, I use, in fact, sectional matrices which are not anterior matrices. I use a combination of posterior matrices, section ones, which are called Kerr Adapt. They are like the metal sectional matrices which we use for posterior restorations, but that was developed long time ago. They don't really work very well for posterior restorations, but they work relatively well for anterior restorations. When I only do, for instance, diastema closure, if I need to do a more extensive form correction, I use most of the time another kind of posterior matrix, also from Kerr, which is the Lucifix. And it has a quite nice curvature. It's not perfect, but it is hello from Peru. We have somebody from Peru. Hello. And those matrices are very easy to shape, so you can really help to follow the anatomy of the teeth. Some people like to use metal sectional matrices, which they basically put upside down. Those have only one real disadvantage, is that they don't allow you to shape palatal and facial, so you can only build up the contact. There is the David Clark or BioClear matrix, but it's more for molding technique, so injecting a sorbal composite. We can use a regular strip, but of course it doesn't give you normally a nice profile, so you have a lot of work to try to deform the strip in order to create a nice proximal contour. But I think there is no system that is really perfect in the sense having a 3D anatomy that can allow us to shape three-dimensionally the proximal or the incisal edge, to reshape completely a tooth. So me, I do, let's say, a sort of primitive shaping of my restoration, slightly overbuilding the anatomy, and then I do a cut back with discs to do the primary anatomy. So the primary anatomy, I will refine with discs. I do very little, sometimes nothing with burrs, apart just from the cervical, or the palatal if I don't use with an index. So I need a little bit of finishing there with burrs.